Thank you for joining our Debbie's Dream Foundation webinar series. Today's webinar features Dr. Samuel Cytryn, who will give a presentation on knowing your biomarkers. I'm Brittany Starks, Communications Director for Debbie's Dream Foundation, and I will be moderating today's webinar. Before we begin, I'd like to thank our generous sponsors for making today's program possible. Title sponsor Amgen, Astellas, Daiichi Sankyo, and Merck. Platinum sponsor Icahn Oncology. Gold sponsor Arcus Biosciences. And silver sponsors Bristol Myers Squibb and Lilly Oncology. First, I will share information about stomach cancer and Debbie's Dream Foundation. Then we will hear a presentation on knowing your biomarkers with Dr. Samuel Cytryn. A Q&A session will follow the presentation. Dr. Cytryn is a Northwestern University graduate with a degree in creative writing. He attended medical school at Mount Sinai. Following that, he served as chief resident at New York University during his internal medicine training. Later, he became chief fellow at Sloan Kettering, specializing in immune checkpoint blockade and targeted therapy for esophageal gastric cancers. Dr. Cytryn is notable for receiving the ASCO Young Investigator Award and for his publication in respected journals, including the Lancet Oncology and the Journal of National Comprehensive Cancer Network. At this time, I'd like to turn the presentation over to you, Dr. Cytryn.
Yeah, thank you for the introduction. Thanks to everyone for joining now and who's able to listen later. I'm happy to be able to discuss this really important topic in this disease. I'm not able. Oh, there we go. Yeah, perfect. Okay, so these are my disclosures and my research funding. Before we get into discussing biomarkers, we'll discuss some other common terms that will really be important in putting biomarkers of esophagus and stomach cancer into the appropriate context. And I want to start with staging because I have patients come in and everyone or many people know the staging of 1, 2, 3 to 4, but I think there's a little bit of an easier way and more appropriate way for how we think of this disease. And I want to just start with, we often categorize it, medical oncologists, surgeons, radiation doctors who treat this disease in these 3 buckets. Very early stage is something that's very small, hasn't really invaded into the wall of the esophagus or stomach, and can be treated just with surgery or resection with an endoscopy alone, and doesn't require intensive medications or radiation that goes, all throughout the body. Locally advanced or localized disease is any cancer that has started to spread. It's invaded a little bit further into the wall or maybe into the lymph nodes in that region, in that area. And this is still treated with a goal of curing the disease. But it really requires all disciplines, a medical oncologist, a surgeon, and sometimes a radiation doctor as well. And this is often, in the stage 2 or 3. And metastatic or advanced disease is synonymous with stage 4. And this means that the cancer has spread from where it started to either a distant site, either lymph nodes that are further away or a different organ. And the foundation of treatment here is with systemic therapy. And we'll talk a little bit about what that means, but it's treatment that goes all throughout the body to treat the cancer cells wherever they are, because the cancer at this time has unfortunately already spread. Another really important distinction is the type of cancer. So squamous cell versus adenocarcinoma. Squamous cell cancers are more common globally. They're less common in the United States. They're really in the middle or upper part of the esophagus and related to toxins like cigarette smoke. And adenocarcinoma is going to be what we're going to focus on more during this session. It's much more common in the United States. These biomarkers are more applicable in this situation. And it's really the bottom part of the esophagus and the stomach, and more related to acid production and in certain situations, a bacterial infection in the stomach called H. pylori. But just another important thing to know when you're thinking about what type of cancer do I have? What is the stage? What is the histology? Meaning this is squamous versus adeno. What do the cells look like under the microscope? And then the next part, these are some terms that I've already started to use, and I know a lot of doctors that you or perhaps family members have seen in clinic use these terms, and we don't always describe what they mean, and I think it's really important. So local treatments are surgery or radiation, meaning it works wherever the surgeon points the scalpel or wherever the radiation doctor points the radiation beam. Whereas systemic therapies, which are prescribed by the medical oncologist, treat the cancer cells wherever they are throughout the entire body. And these can be pills or intravenous infusions. And then different categories of systemic therapy are chemotherapy, which indiscriminately kills rapidly dividing cells. So this is our oldest cancer treatment. It's kind of like a sledgehammer. And then some of the newer treatments, which are really guided by our biomarkers that we'll talk about. So immunotherapy, immune treatments are intravenous treatments that stimulates the patient's immune system to recognize and attack the cancer. And targeted treatments, which can sometimes, when I'm speaking with patients, there can be confusing targeted versus local. So targeted is a systemic treatment, but the difference is it is focused on something that the cancer particularly expresses, so it goes to attack the cancer itself rather than just indiscriminate cell killing. And we'll talk about some examples for that as well. So before we talk about the different types of biomarkers, let's talk about what a biomarker is. So a biomarker is it's a characteristic of the tumor. It's usually a protein or a gene, and it's indicative of the biology of that particular cancer. And so it guides us as to how this tumor is going to behave. And so a biomarker can be prognostic or predictive. Prognostic means it gives us an indication about how aggressive this cancer might be. So is it going to be more aggressive and more likely to spread, or do these patients with this biomarker do well? Versus a predictive biomarker has more to do with the sensitivity and response to a particular type of treatment. And there's some overlap in these types and these definitions that can be a little bit difficult to understand in hypothetical terms, but I think it will become more clear as we go through specific examples. So let's start with that. So these are the three standard biomarkers that any oncologist who's treating gastroesophageal cancer has to know before treating their patient. Mismatch repair proteins and microsatellite instability, HER2, and PD-L1. These are standard. These are all able to be done in a clinic and should be known before treatment is started because they affect the treatment. And then as we go through, like I said, we'll put this into the context of the stage of disease, because what's approved, what's a standard treatment is affected not just by the biomarker, but where it is in, has the disease, is it still a potentially curable situation, or has the disease spread and it's more advanced and requires more systemic, treatment rather than going for cure necessarily. Okay, so let's start with mismatch repair and microsatellite instability. So first, let's start and talk about what is this. So mismatch repair proteins are essentially the copy editors of your DNA. When your DNA is replicating, it makes mistakes, and these mismatch repair proteins fix those mistakes. Now, if there is a mutation in the gene that makes these proteins and you no longer have these proteins, your DNA is prone to make a lot of mistakes, as is the cancer's DNA, and it can lead to a lot of mutations. And when there are a lot of mutations, that's called microsatellite instability. And I put both of these terms here, mismatch repair protein deficiency and microsatellite instability, high, meaning there's a lot of mutations, because one causes the other, and we often use them interchangeably, even though technically they don't mean the same thing, but in the clinic you might hear your oncologist using them interchangeably. But a couple of differences are mismatch repair proteins, we can figure out that test in just a couple of days because we look at it under the microscope and say, okay, with the staining, are these proteins there or are they not there? And microsatellite instability requires sequencing of the DNA of the tumor itself to see, okay, does this tumor have a lot of mutations or not a lot of mutations? And that takes on the order of weeks. And of course, we don't want to wait several weeks before we start treatment. So we use mismatch repair protein deficiency as a surrogate for microsatellite instability. And that is the case that there is this direct cause over 95% of cases. So it is a good surrogate for us to use. Okay. So, but what does this mean? Well, it is a good prognostic biomarker, and that was what I mentioned before, because it's rare in that it's only present in about 5% of metastatic cases, but it's more common in localized cases. These numbers vary based on the study. They're relatively, so it's not very common, but it is important because it tells us that these tumors are very sensitive to immune therapies. And so that makes it a good predictive biomarker to immune therapy. Because it leads to so many mutations in the tumor, once the patient's immune system is stimulated by immune therapy, it does a really good job of recognizing these tumors and killing them. Most of the time, this is a sporadic or otherwise random mutation that occurs in the tumor. However, in a significant minority of these patients, it can be something that's called due to a germline mutation or an inherited mutation. This is a syndrome called Lynch syndrome. So anytime a patient's tumor is found to have mismatch repair protein deficiency or microsatellite instability high tumor, then it's imperative that the doctor do germline genetic testing and refer the patient to a genetic counselor in the event that it's positive, because this has implications for screening for other cancer types in this patient, as well as for family members. Okay, so putting this into the broader context, starting with advanced disease on the bottom left here. Sorry, I thought someone had said something. Okay. Like I said, these tumor types are very sensitive to immunotherapy. So immunotherapy is going to be the backbone. Because there may be some cells that are not necessarily mismatch repair deficient, we also use chemotherapy. This is approved to be given together. However, because immunotherapy is the heavy lifter, the driver of the response in these patients, that's the central component. And sometimes we pull back on the chemotherapy. Going up a little bit to what do we do for these patients who we're trying to cure? It becomes a little bit more complicated, and as you can see, there are technically three possible options here, and that is really owing to the fact that in the United States, this is a rarer disease, and this is a smaller pie of this disease. So we know that treatment with chemotherapy before surgery, chemotherapy doesn't work as well, it's just delaying surgery. So a standard option would be just, if it can be just taken out, go to surgery, have the tumor removed. There are some newer studies that have looked at giving immunotherapy first for a short period and then going to surgery, and the outcomes are very encouraging. So this is also an approved option. Because these are smaller studies and they weren't technically randomized, both are options. It's not definitive, but either way, I think it's really important to know that immunotherapy needs to be a part of treatment in the advanced setting and can be a part in localized setting. And if it's not, then just surgery right away. And we'll talk about how that compares to some of the other biomarkers. So let's go on to HER2. What is HER2? So it's a normal protein that's expressed on the surface of normal cells. It tells cells to divide. HER2 positive means there are too many of these proteins, on the surface of a cell. So the cell just divides and divides without stopping. And at its definition, that's what cancer is. This occurs about a fifth to a quarter of all stomach cancers. When I explain this to patients, because breast cancer is so much more common, particularly in the United States, than stomach cancer, a lot of people have heard of HER2 positive breast cancer. We're talking about the same HER2 protein. How common it is in stomach cancer depends a little bit on the location in the stomach, but generally about a fifth to a quarter of stomach cancers are HER2 positive. This is not related to anything that can be inherited. So there's no necessary genetic testing from a germline or inherited perspective that needs to be done. Before we started talking about targeted therapies, so trastuzumab is an antibody that targets HER2, and trastuzumab deruxtecan is an antibody with a chemotherapy payload on it. So it tries to direct where the chemotherapy is given to the cancer cells that are expressing HER2. And just a quick tangent about some of this nomenclature and some of these namings, any medicine that you see that has an MAB at the end is a monoclonal antibody. So trastuzumab is a monoclonal antibody against HER2. Okay, so continuing to put this in the context. And let's start again with advanced disease, metastatic disease. So we know immunotherapy plus chemotherapy, but now we're also adding trastuzumab. And that is targeting the HER2 protein and also recruiting the immune system to attack the cancer cells that we know express HER2. If patients get this treatment, this combination regimen, and their disease unfortunately progresses, it's growing, it's continuing to spread, then we go to a treatment called that treatment that I mentioned called trastuzumab deruxtecan, which is the antibody but with the payload chemotherapy targeting it. Moving to patients with earlier stage disease, unfortunately, we don't yet have the targeted treatments for this type of disease, for this cancer in this stage. So the standard treatment is run-of-the-mill. It's chemotherapy followed by surgery, followed by chemotherapy, or chemotherapy with radiation together, followed by surgery. And then depending on how much the cancer shrank after surgery, considering immunotherapy. These two options are the standard options and that have been around for several years, one of these going on beyond a decade. And we can talk a little bit about them later, but as you can see, they're not biomarker driven. We're not there yet, and I'll talk about that a little bit later, but these are the two standard approaches. So let's talk about PD-L1 next. PD-L1 is a protein that's on tumor cells, and it's also on immune cells, so the immune cells that are trying to attack the cancer. This is a predictive biomarker in that how high the PD-L1 expression is gives us a sense and tells us how well it's going to respond to immunotherapy, okay? It's calculated as a percent of all the cells, how much is PD-L1 is expressed on the tumor cells plus the immune cells in the neighborhood, and it's scaled 0 to 100. Negative, less than 1 or 0, sometimes it's expressed as one or the other on the report. 1, 2, 3, or 4 is considered low, and 5 or above is considered high. So PD-L1 high, we know has a better chance of those tumors responding to immunotherapy compared to low or negative. Now, this is where things become a little bit complicated, particularly in depending on where you're getting treatment, because in the United States, immunotherapy in addition to chemotherapy is approved regardless of the PD-L1 score. However, in Europe, until recently, it was only approved if you were PD-L1 high, meaning a score of 5 or above. Although just recently, there was an approval that it's now PD-L1 1 or above, so just positive. And when we think about putting this in the context, again, starting at the bottom, we know immunotherapy is helpful in PD-L1 high, but you still need to be treated with chemotherapy. So they work together, in contrast to the MSI high patients where it's really, really responsive to immunotherapy. And then again, as you can see in localized disease, disease where the cancer has not spread, we're still not at a point where we're using the biomarkers to guide treatment yet. So part of this is because patients who have localized disease compared to advanced disease, they do better, which is of course great, but it just takes longer for these treatments to see if they're working. Sorry, there was a bit of feedback. But so we don't know yet if immunotherapy plus chemotherapy works better than chemotherapy alone in early stage disease, but these clinical trials are ongoing, as are trials looking at trastuzumab with immunotherapy with chemotherapy compared to chemotherapy. So unless you have mismatch repair protein deficiency, your treatment for early stage disease should involve chemotherapy and surgery, and sometimes radiation, but that's a little bit of not related to biomarkers necessarily, more related to physically where the cancer is in the esophagus, higher versus lower. And if it's in the stomach, it should definitely be chemo, then surgery, then chemo. Okay, so these are the standard biomarkers. So where are we going next? What do we expect to see in the clinic in the coming really weeks, hopefully soon, and months and years beyond that? I want to start with Claudin 18.2, and you'll see sometimes it's written as CLDN. This is a protein that's on normal stomach cells, and in about 35 to 40% of stomach cancer cells, this protein is expressed on the surface of those cells. Different than HER2, it's not driving the cancer. It's not telling the cancer cells to divide and divide. It just happens to be there on normal stomach cells, so then it just stays and happens to be there on stomach cancer cells. The reason I make this distinction is because it is a target for an antibody that goes after Claudin, but some of the nuances are different. And there were just 2 very large international randomized phase 3 studies. So the best type of clinical trial that can be done to approve an agent, and they said, okay, chemotherapy compared to chemotherapy plus this Claudin antibody, zolbetuximab, so the MAB, the monoclonal antibody against this, and the patients who got the monoclonal antibody against Claudin plus chemotherapy did better and lived longer than patients who just got chemotherapy. So we are hopeful that being able to look for Claudin in our clinic and see if your cancer cells, if the patient's cancer cells are Claudin positive, and then use this antibody will hopefully be coming in the coming months. It's not yet approved and we can't yet do it, but hopefully in the coming months. These last 3, FGFR2, EGFR, and MET, are other biomarkers that would be specific to a patient's particular stomach cancer, for which there are other antibodies that are being worked on. FGFR2 is a little bit further along than the other 2, but I think all of these may be targets for medicines and antibodies and antibody drug conjugates. Remember the targeted antibody with the chemotherapy payload in the future. So just things to keep your ears out for, but nothing that is guiding what we're doing yet. Next, I wanted to talk about what's called next generation sequencing. And this may be something you've heard, and at this point, it's should be done so routinely, it should in some ways be called this generation sequencing, but this is looking at the DNA specific to the tumor to look at a whole broad list of mutations that may help guide a clinical trial. And if you think back to when we were talking about microsatellite instability, that is detected based on next generation sequencing. And so that takes on the order of a few weeks. This is usually done on the tissue of the tumor. So someone will have a biopsy, usually with an endoscopy or a needle biopsy, and then we send that tissue for sequencing. However, something that's new that's coming to not in the clinics yet, but hopefully coming soon, is this idea of a liquid biopsy. So what does that mean? So you can see in the picture here that the tumor has proteins and the DNA that makes up the proteins, and that is shed into the blood. And so if you draw someone's blood, it might be possible, or it is possible in certain circumstances, to look at the tumor DNA just by drawing someone's blood and look at their tumor that's only in one area. So what are some of the limitations? What do we think is coming next with this? Well, you can imagine that someone who has cancer that's in the stomach, but's also spread to lymph nodes and their liver and their lungs, the tumor is, there's more tumor cells everywhere. If you draw the blood, it might be easier to detect the tumor DNA just by a blood draw, compared to someone who just has a tumor in their stomach or in their esophagus, and maybe it hasn't yet spread to the lymph nodes, then maybe it hasn't spread to the blood, so it's not as easy to detect. One use of this is going to be, can we detect mutations just by doing a blood draw as opposed to doing a more invasive procedure? Another option will be to try and stratify patients and say, okay, someone has cancer's just in the stomach, it hasn't spread. Well, can we see if maybe there's a signal of it in the blood, to see if there are cells there that haven't yet become officially metastatic and haven't spread to the liver? Can we maximize treatment at this stage? These are some of the questions we're trying to ask, but still not ready for prime time yet. But these are a lot of the research studies. So I know we went through a lot, but I wanted to make sure to leave time for questions. I think it's important to know the stage of your disease and think more early versus localized, but it started to spread in the neighborhood versus advanced, the histology, squamous cell versus adenocarcinoma, and then think about this in the standard biomarkers, mismatch repair deficiency versus microsatellite instability, as one, sort of surrogate names, one for the other, HER2 positive and PD-L1 on a spectrum, what these mean for your treatment, and how putting that into the grid of advanced disease versus potentially curable disease. And not yet ready for prime time, but we're getting pretty close, especially with Claudin inhibitors, then maybe a little behind that with circulating tumor DNA and liquid biopsies. And a little bit further away are some other biomarkers and some other targets, but there are clinical trials looking at those now. And I think that was all I have. I'm happy to take any questions.
Thank you so much, Dr. Cytryn. I'm actually going to ask that you control the mouse for the following of the presentation, because we had some technical issues, but it looks like you were able to navigate. You can go back to the screen of the questions. And so we did have someone who asked the question, for someone who is newly diagnosed, how do I go about requesting biomarker from my doctor? I think she's saying, is that standard practice of care?
Yes, so great question. And it should be standard of care. And I want to answer it in sort of two situations. So in one situation, if the cancer has already spread, it should be, to my knowledge, every clinic and every doctor I've spoken to who treats this disease at multiple institutions, not just at a specialized cancer center, mismatch repair deficiency, microsatellite instability, HER2 and PD-L1 should be reflexive, meaning they do an endoscopy, they take a biopsy. The pathologist, the doctor who looks at it under the microscope, says, this looks like stomach cancer. It should automatically send off those other 3 tests. And then the full report that goes to the oncologist, that now, because of electronic medical records you have access to, but your doctor should have access to immediately, should say, this is stomach adenocarcinoma. It is mismatch repair protein proficient or deficient. The PD-L1 score is anywhere from 0 to 100, and it is HER2. And then there's some more nuances with the scoring system, but ultimately it will tell you if it's HER2 positive or negative. So that should be automatically reflexive. In earlier stage disease, so potentially curable, locally advanced, localized disease, it is not necessarily reflexive everywhere, meaning they do the endoscopy, they see it looks like stomach cancer, you get scans head to toe, they don't see that your cancer has spread anywhere. Because it's not yet standard to change treatment with trastuzumab or use immunotherapy, it is not reflexive everywhere, but it is important to ask, because in that small, you saw about 5 to 10% of patients are mismatch repair deficient, that would change treatment. It should be able to be performed. So it would be important to ask. And that test is, again, just staining the biopsy that they did with the endoscopy, that they got with the endoscopy, should take a handful of days. So it's not something that would meaningfully delay treatment, but it would change treatment.
Thank you for that answer. Another question, biomarkers, does it play a major role in whether or not a patient would get offered a clinical trial?
It can. And so the reason that it would affect that is, I can give some examples. So a clinical trial, there are clinical trials, it depends on where you are, where they're open, but that are looking at HER2 targeted therapy in localized disease. And so that's only going to include patients that are HER2 positive. And in other in advanced disease, maybe they want to do a better HER2 antibody, a newer HER2 antibody. So they would only choose patients to go on that clinical trial if they're HER2 positive. Similarly, because we know some PD-L1 scores, the higher it is, the more likely it's to respond to immunotherapy. They may want to test, are you low or high, because we have this new immunotherapy and we want to try it in PD-L1 low patients. So, or patients whose tumors are PD-L1 low. Sorry. So it is important to know the biomarkers for clinical trials. For the standard ones, a lot of the time they'll do it in clinic, but sometimes the clinical trial, depending on the stage of the phase of the clinical trial, will want what's called centralized testing. So centralized testing means rather than just doing it in the clinic, the tissue sample is sent to one place so that they have the same facility doing the testing to eliminate variability or limit variability. So it certainly does affect clinical trials.
Thank you for that. Janice Martinez asked, why would my oncologist tell me that immunotherapy isn't something that was needed during my TX? I think she said, I'm stage 3B adenocarcinoma signet ring cell. Is there a huge benefit for someone like me to have immunotherapy?
So my guess would be if you had a stage 3 signet ring tumor, you probably got chemotherapy followed by surgery followed by chemotherapy. And immunotherapy is not used in that situation. And I know on the slides I had, there was an option for possible immunotherapy if you get radiation. The difference is in that situation, the chemotherapy that's given before and after surgery in stomach cancer is more intense. And because you can imagine if you're giving radiation, you can't give as much chemotherapy. So they've actually, it becomes nuanced, but it was not incorrect to not give immunotherapy in early stage disease, in stage 3B stomach cancer with signet ring cells. It sounds, I don't know that your specific case and specific situation, but it doesn't sound like that was an incorrect treatment from my understanding of what you mentioned.
Thank you. She said, thank you very much. If anyone else has any questions, now would be a good time to type that in. But this has been a very informative presentation, Dr. Cytryn. Thank you so much. Is there any takeaways that you would want anyone to consider or to walk away with? Any information they should know?
I think the first couple of questions were really important because when you or a family member or friend is sitting down with your doctor, and obviously you get so much information in those first visits. I think really distilling, if the only things that you walk away with and make sure to write down are, is this, what stage is this? Are we in the sort of curable or advanced? And then what is the PD-L1 score? What is the HER2 score? What is the mismatch repair protein proficient or deficient, because treatment shouldn't be started unless you know those things. And that then allows you to answer, taking the second question in mind, look for clinical trials, because it can be so overwhelming to hear all of this information and then try and navigate the process, that this helps you focus on what specifically the treatment should be for, you or that patient's specific cancer type, because that's where cancer treatment in general is going. It's no longer just stomach cancer or, esophagus cancer treatment. It's okay, we're subdividing every different type of cancer based on its biologic features. And that's what the biomarker is. It's based on the features that tell us about the biology of the cancer, so that we can tailor the treatment to whatever the situation is. And the clinical trials and the standard treatments are reflecting that. So I think that's what my takeaways would be.
Thank you. We have Kataziner, I think. I'm so sorry if I pronounced your name wrong. Are biomarkers differently expressed in minority patients?
That's a really good question. And to my knowledge, not that we have seen. It's more reflective of the location of the tumor than the patient's ethnicity. And what I mean by that, which is in some ways a little bit dependent. So to give you an example, in East Asian patients, they more often have stomach cancers that are in the lower part of the stomach, whereas in the United States, which I know or in Western European populations, it's more the proximal, so the higher part of the stomach and the lower part of the esophagus. And so the distinctions are, the claudin expression is higher in the further away part of the stomach. HER2 is more common in the upper part of the stomach. But between, so in some ways it is, but not to my knowledge otherwise.
So much. We have a comment from Lisa Moore. She says, thank you so much. This was so helpful in making this complex topic more understandable. And we're happy to provide this information. Thank you for being here, Dr. Cytryn, for that important information and making it easy for our audience to understand. And then we have another question from Jennifer, who says, you briefly touched on EFGR. Can you expand more on potential new findings and research?
Yeah, so EFGR is another protein on the surface of a normal protein on the surface of normal cells, and similar to HER2 on a small number of stomach cancer cells, it can be overexpressed. So there's too much of this normal protein. And so there are antibodies targeting EGFR. Some of these antibodies are actually used in lung cancer, where it has some approvals, and we're seeing if they work in stomach cancer. Some of the challenges that make this a little bit further away is, number one, it's just in a handful of % of patients that have EGFR overexpression or amplification. It's about 3%, so it's an even smaller part of the pie. Number one, and so that makes it a little bit harder to try and find these patients. But that's one of the reasons it's important to do this biomarker testing to see, because next generation sequencing gives us a whole panel, and so people don't necessarily know unless you look. But so it's not approved yet. It's only an earlier phase clinical trial, so still has a couple of steps to go before these antibodies will be used.
That concludes the questions that we have so far. Thank you so much again, Dr. Cytryn, for your expertise in this amazing presentation. I'd ask that you please click to the next slide for me.
Mm-hmm. Yeah, and thank you for all the engagement and the questions, and for the chance to be here.
Absolutely. We couldn't do it without your expertise as well. So thank you to our audience for tuning in. As you can see here are listed some of our upcoming events and programs leading into November, which, as you may know, is Gastric Cancer Awareness Month. And these are some of the upcoming programs that we have. So please check out our website and please do look into more ways to get involved and help raise awareness during Gastric Cancer Awareness Month. Next slide, please. We'd like to once again thank all of you for tuning in today. We'd also like to thank our generous sponsors listed here: Amgen, Astellas, Daiichi Sankyo for title sponsor, platinum sponsor Taiho Oncology, gold sponsor Arcus, and silver sponsor Bristol Myers Squibb and Lilly Oncology. Thank you also again to Dr. Cytryn for being a wonderful host of today's program and sharing amazing information that helps our community better understand how to navigate their journeys. Until next time, you can find more of our programs on the DDF website under Lecture Library, and stay tuned for our next upcoming webinar under Events on our website. Until next time, enjoy your afternoon.
Thank you, everybody. Stay safe and stay well.